Good morning, everyone. We are live on 95th Roundtable Expert Meeting Group. And today we have a very important topic, critical care management for pediatric patients for the second and third and preparations for that. Over to Dr. Kalra, who's the former CEO of NABH and Director of Heart Care Foundation of India. Thank you.
Thank you. Thank you, Saurabh. Good morning to all. And I welcome to this 95th weekly session of Heart Care Foundation of India, which was started by Dr. K.K. Agarwal. Today we'll be discussing sharing of innovations done for critical care management of pediatric patients during second wave and preparing for the third wave. Today we will be having speaker Dr. Satish Theopujari. He's an innovative physician and Professor Emeritus Indira Gandhi Government Medical College, Nagpur. He is active member of so many other associations. He is very much involved deeply into innovations regarding especially the ICU life-saving equipments. And today we'll be presenting his innovations, especially the ventilators and other things, along with his colleagues. And for comments, Dr. Vidya Rata Ghosh. She's a pediatric intensivist, Yashoda Hospital, Ghaziabad. So before I hand over the mic, I will request Dr. Jamkar to chair the session today. I will briefly just give the update regarding COVID situation. Saurabh, please allow me screen sharing. Saurabh ji. Oh, Saurabh has forgotten to. I will just call Saurabh. Saurabh. Comes overall COVID situation in India is now for last 2-3 days. This week comparatively there is a dip in cases all over India. In the last 24 hours, 2,51,209 cases, new cases were reported in the last 24 hours and 627 deaths. Positivity rate pan-India average is 15.88%, and total vaccinations given is 164 crores roughly. And on Tuesday, the DCGI has also given approval for clinical trials of nasal vaccine as a normal vaccine for COVID as well as for use as a booster dose in India. Maharashtra is also now showing it is declining trend. Yeah. I can share the screen now. I will just, if you see overall globally, this week ending on 25th of January, overall 5% increase in cases and 1% increase in death has been seen all over the world. And this week, maximum cases were seen from Eastern Mediterranean and Southeast Asia region. America's region has reported a 10% decline in new cases, and deaths are only 7%. South Africa, we can see that decline, that trend still continues, and it's settling down. The Omicron, from where this all spread to all over the world. And India, if we see for last 3 months, and this is the whole 1 year graph on the left side down, and the right side in the 3 months, we can see now for last few days, definitely there's an indication for decline in the COVID cases. And if we see this week, 16 states and union territories have seen the 7-day average, the new cases dropping down more than 20% from the third wave peak. Maharashtra definitely for last few days is showing decline. Then Delhi has very much a declining trend. Now cases being reported per day is very less, around 4,000. Delhi has reported 4,044 cases in the last 24 hours and 25 deaths. Kerala still, it is still not showing the dip in cases. And Karnataka also, although for a day or two, slight dip, but still we need to observe for 1 more week time to comment about the Karnataka state. Tamil Nadu, almost same trend, not typical declination has not started. Rajasthan, definitely cases are coming down. UP also a clear decline trend we can see. And Mizoram is still showing cases and not starting the decline trend. And overall, if we see in India, 86.5% of the hospital beds are vacant. This is a state-wise, you can see details. And now, from the urban metros, there's a decline trend. More cases are being reported from the peripheral and rural areas. So that is likely. Initially, we saw the Omicron maximum number from the urban areas by and large, and there are very less number of in rural areas and distant areas. But now we see metros are declining and cases are now being reported from distant, far distance areas and rural areas. Now I will hand over to Chair Dr. Arun to take further the proceedings.
Thank you, Dr. Kalra, for inviting me to chair this session with Dr. Satish Dev Pujari. I think what you can describe him, he's an innovator and a clinical innovator. Am I audible?
Yeah.
He's a clinical innovator, and I think he is almost a boon to the society and for a better healthcare. And we have some concept called physician scientist, where some program would be coming soon in India. And I think Dev Pujari could be one of that, where he is not only physician, but he has created a lot of innovations. I share a lot of things with him because I have also fascination for technology. And I just went to his website that following are the areas of Dr. Satish Pujari's ongoing research: oxygenation through the source other than skin, and Nagpur sensor project with Dr. Singru from BITS Goa on developing a sensor at the tip of endotracheal tube, a simulation from locally available sources, and simulation from ABG interpretation. I think I won't go into much detail because I have to give time to him. And I just congratulate him for creating an entirely new type of a ventilator. And last time we discussed about its limitations and excellence. And Dr. Kalra had requested him to demonstrate Maybe after a demonstration, we can have a lot of discussion. Yesterday, I was just investigating 2 ICU deaths in symbiosis, and then both of them, they were some sort of miscommunication between the ventilator and the doctors or the nurses. One patient was accidentally extubated, and then nothing took place, and then subsequently they were able to intubate. Other thing was it was disconnected, and where that alarm was there, but then nobody listened to that alarm. So I thought Yoga Pujari might be a right guy. Just create some sensors and maybe IoT or something for better ventilated care. Thank you. Over to Dr. Yoga Pujari.
Am I audible to all of you?
Yeah.
Yeah. Thank you, Chairman and friends. It's been a nice introduction, and I'll try my best to put across as to what we did as a team last 2 years, because I'm basically into intensive care, pediatric intensive care. And I was the first chairman in the country in pediatric intensive care about 25 years back. So that is close to my heart, and so is true of the technology. So when we saw so many patients dying and Nagpur was very badly affected, it touched us. We formed a group. So I'm one of the physicians, and I have a brilliant technology team. Abhay is here. I think Tejas is from Pune. He could not join. So this, we named it as Satej, and we started making an invasive ventilator. We were almost through the process. The ventilator was ready. At that moment, we decided, and as a clinician, I suggested my team to change our path to non-invasive ventilation. The fact today is about 80% of patients are on non-invasive ventilators. And non-invasive ventilators does not mean that it is easy to start or easy to maintain. Neither it does not mean that it is easy to make. In fact, one of the very complex technologies is making an invasive ventilator. Essentially, a non-invasive ventilator would mean that we are ventilating a patient without intubating. And since this is true, what happens is that there's a continuous leak of gases. So you'll have to monitor pressures, flows, and the dynamics in an open system, very fastly responsive to the changes. And that is why literally no one in our country tried making a non-invasive ventilator. And God has been kind to us. We could make a very efficient non-invasive ventilator. I presented this across the globe, and including our country like AIMS and PGIMS, and all of them were very happy with this machine. So what I will do is, in about 20 minutes, I'll take you through what we did in 2 months in COVID, run you through these things, and then my colleague Abhay would lively demonstrate you the machine with all its functions. Now I'll share the screen. Oh, I think there's some, 1 second.
Yeah, you need to change settings. Yeah.
Yeah, that's what I'm doing. Yeah, so I might have to disconnect for a while because the I'll just come back to you immediately. Give
Yeah.
me a minute.
Till Dr. Dev Pujari connects, good morning to all of you. Sorry for being late.
Good morning, sir.
Good morning, Dr. Kalra. Good morning, Professor Vijay Mishra. मेरे हम नाम जब कालरा ने कहा कि I will request Dr. Arun to chair, तो मुझे लग मैं बोलने वाला था थैंक यू वेरी मच डॉक्टर कालरा. देखा ना ये नाम एक नाम होने के क्या एडवांटेज और डिसएडवांटेज.
Yeah, both are same to us. Very good, very good. So while we are waiting for Dr. Satish to join us, I had a proposal, Dr. Kalra and all my friends in the round table. You know, we're going to touch 100th meeting in March.
Yeah.
And 15th March is observed as World Consumer Rights Day. So I was just thinking if we can think of celebrating the 100th roundtable, dedicating on patient safety and on issues concerning accessibility to healthcare in the country in terms of universal health coverage. I'm very keen that that should become a mission amongst us in terms of, like we are talking about innovation, we are talking about quality care, we are talking about how to make healthcare accessible. So I would be very delighted if you all agree that whenever we celebrate the 100th week, if you all can consider this proposal of mine.
Sure.
Sure.
15th March is which day?
15th March, I don't know.
ये देखता हूँ मैं.
I'm looking at the 100th meeting.
15th actually Monday, Tuesday.
No, we can have it earlier. I mean, what I'm trying to say is that we can always say that we're going to celebrate the 15th March.
Yeah.
Because there was also a proposal amongst the roundtable to talk about improving accessibility through insurance cover.
Yes.
And there is a great need to make people aware, because more and more deeper I'm getting into that subject, I find there are some wonderful products but not intentionally sold by the insurance companies. So people should start demanding and accessing those products which are there. And you see, most of the insurance companies in general insurance do not promote healthcare because it is not a profitable product. So they always are eager to promote such products which are more profitable and profit earning for them. But the government and the regulator are insisting on them to ensure that they spend more money on publicity of healthcare products, which is today missing. So we as citizens need to take it up, because the insurance companies will not do it and we have to do it.
Fine. Agreed. Dr. Satish has joined. Let him now.
Yeah.
Start. Dr. Pujari, please.
Sir, you are mute.
नहीं, unmute है.
Unmute है. Are you able to share the screen?
Yeah, 1 second. I'm trying. 1 second.
You first open your PPT and then minimize your Zoom. Minimize your Zoom. Open your PPT and then come to Zoom. Open it up.
Yeah. Yeah, the PPT is open.
Before you open the Zoom, you have to first
Yeah.
open on the desktop your PPT.
And then
Yeah.
go to share screen, the green button at the bottom.
Yeah, the PPT is open.
Go to share screen in the
Yeah.
Zoom.
Once you have the share screen, all the desktop will open, and then you have to select that desktop which has your PPT. So all programs open
Yeah.
will be seen.
Yeah. Just give me 1 second.
Actually, I was very much interested in connecting all these ventilators through Wi-Fi mechanism.
Yeah.
That last time I told you about it.
Abhay,
Yes, sir, I'm there.
can you start from your end? Then I will, because there's some.
Sure. So should we start with the machine straight away?
Yeah, please.
Yeah.
Okay. Fine. So one sec.
No.
So all are able to see the machine?
Yeah.
Okay. So this is the equipment called Prana Setu, which was devised. And this equipment is basically a non-invasive ventilator. First of its kind, for a reason that we have been going through high flow nasal cannulae as an equipment, Cpap as an equipment, BiPAP as an equipment, and then another equipment added onto it, the humidifier, because all non-invasives, normally you route it through a humidifier. So all these four things, we have blended it into this equipment. And if you are able to see on the top of the machine, you have a humidifier mounted. So this is an all-in-one kind of an equipment which has all the three modalities of delivery: the high flow nasal cannula, Cpap, and BiPAP. In BiPAP, all three modalities of BiPAP, that is spontaneous, timed, and spontaneous timed, all three versions of BiPAP available. My colleague here would take us through the running of the ventilator. This machine is based on the platform of high-end ventilators, so that in an ICU, people are able to relate with it, and they don't have to relearn things again and again. So typically, if we see the screen now, I have the patient ID mentioned. Dr. Jamkar was just mentioning about connecting it to Wi-Fi and all. So we need to have an ID. The patient ID is necessary. So my colleague would just punch in a patient ID now.
भाई आप इसको full screen पे दिखा सकते हो?
जी दिखा सकते हैं. If somebody can give me the rights to project, I can do it probably.
Kalra?
Yeah.
Even if you can pin this screen, the screen that I am talking through, you'll be able to see it full screen, sir. You go to the active speaker mode, you will be able to see my screen on a larger thing. Yes. Okay. So you have it on the larger screen now.
Yes.
So once the patient ID is punched in, you have the patient categories, that is adult and pediatric. Since we are talking pertaining to pediatrics, let us have pediatrics.
You are allowed to share screen.
Okay. If all are okay, and if you already have my screen on spotlight,
Yes.
then I might not have to.
I can see full screen.
Perfect. So now on this screen, what you have is she selected pediatrics as a mode, and now the equipment is asking her to select the type of tubing that you're going to use. So you have a choice between the Fisher & Paykel branded tube of 22 mm and any other 22 mm dia tubing. So since we have connected the Fisher & Paykel, I will ask her to connect FNP as a choice. Please go ahead. select FNP. So the moment she has selected the tubing, all my modes have got activated, wherein you have the HFNC, Cpap, BiPAP modes being shown on the screen. I would ask my colleague to select the HFNC mode first. Now, typically what we have tried to do is that every mode has got its specific adjustments. So only those adjustments are seen live. So here in the HFNC mode, you have the flow, the FiO2, and the temperature. The temperature mode is the temperature setting is something which is additional apart from any other ventilators, because you are adjusting the humidifier settings also through the same equipment. So this becomes very handy. Times of COVID, we wanted machines to have least settings. Even otherwise, I would suggest that having least settings, people would prefer using those equipments. So here you have a flow in HFNC. Since it is in pediatrics mode, we have given a range of 2 to 20 liters per minute as a flow setting. In adults, we have about 80 liters, 10 to 80 liters as a flow. So we have selected 2. I would ask my colleague to change it to 5. Yeah. And very simple, you have a start knob here. You can just start HFNC. Yeah, please go ahead. So on the screen, you have 2 waveforms shown. The one in red is the pressure waveform, and the one below that is a flow waveform, which is a constant line. Since it's high flow nasal cannula, you will have a constant flow being sent. And since she's interacting with the nasal cannula, you are able to see the interactions in terms of the pressure feedback. This pressure feedback, we use it to titrate the required flow for the patient. How is a question, and the answer to that would be that whenever there is a change in demand from the patient end, the pressures would reduce. Typically, when I'm showing it now, when the patient is breathing in and breathing out, you are able to see a nice pressure change there. And if the patient is maintaining something like this, he is probably able to get a proper inhalation and exhalation. But typically, I'm just demonstrating this. When the patient is doing this way, I can very well say that he is starving for the gases. So I should increase the flow. So very, very intuitive tool which can give us a guide into titrating the HFNC flows. So it's like up till now, HFNC was a mode wherein flows were assumed. Like typically in adults, they used to use flows as high as 60 liters per minute. And when we studied it, we found that a normal adult is able to breathe in comfortably on 35 liters to 40 liters per minute. That's a net saving of 20 liters per minute. We have all gone through the pandemic showing us scarcity of oxygen, wherein a lot of patients were on HFNC, and that too at 60, at times 70 liters per minute. So that's the titration tool available. This is a tool available and open for all to discuss, and let us try and perfect it in coming times. So that's about the HFNC mode. If there are any questions, I can take those, or I can move ahead on the next mode.
So Abhay, 1 second.
Yeah.
So, what you saw here is a very interesting concept. Almost all HFNCs across the globe don't show pressures. And since I was a pediatrician, pressure is a very important thing for us. So I requested our team to show pressure as well. And they could do that. And because we see the pressure, we can organize the flow depending on what pressure is achieved. So this is one difference that we have in this machine. And as you can see, the graphics is one of the finest graphics across the globe. None of the non-invasive ventilators show this kind of graphics. So this is an important point that we have on high flow nasal cannula. To optimize flow, we have shown the pressure.
Dr. Devapujari, can we have entitled CO2 connected to this?
Yeah, I mean, entitled CO2 is never connected to a machine. As an integral part, it could be a part of the system, but we don't have a facility to connect ETCO2 to this machine.
Because that sensor can give a feedback, and maybe because we are not ICU expert, this is a little common sense, so that we could increase
Dr.
the
Ghosh
pressure.
is here. Dr. Ghosh is here. Let's ask her comments. Dr. Ghosh, are you there?
Yes.
Please give your comments on this, whatever has been shown.
Yeah, I also feel that this is a very good machine which is showing the graphs, and we are not getting, we are not having this kind of machine which is showing the graphs and pressures, and it will help us to control the flow to the patient, and it will help us for we will have less lung injuries with this kind of machine, and really it's a very good machine, I'll say. And I want to know actually what is the cost of this kind of machines, because we don't have it right now.
That will come on later on. First, let's see all the into it.
One
Then we'll discuss.
One more thing. When we are operating these machines, both the oxygen and air connection is required?
Yes.
Right. Okay.
Since it's an ICU. Yeah, please go ahead.
And that way we are controlling the FiO2 for the patient, right?
Yes.
So can I come in now? Most of the non-invasive ventilators would actually not control FiO2. You will have to have an FiO2 meter to know what is the FiO2 generated. This machine is like a high-end ventilator. It has a fully smart controlled FiO2. So you set an FiO2 and then start the machine. Unlike other machines where you try and kind of guess what the FiO2 would be depending on the oxygen and airflow. So here you set the FiO2, which is an advantage like in any other high-end ventilators have.
And
it is electronically controlled.
Since it has come for discussions, I would like to even announce that we have, for the first time in the industry, used a volumetric method of calculating the FiO2. We have used 2 flow sensors inside the machine, which actually calculate the amount of oxygen and the amount of air passing through, and it gives you an exact estimate of what is being delivered. Up till now, we used to know through an FiO2 sensor as to what is the FiO2 concentration in the airway. Here, we have tried to, since a lot of brains were put together, suggestions came in, and we have for the first time used a volumetric method, which is a standard in engineering, where people would like to first measure it and then send it into the circuit. So that is the method which we have used for FiO2. So you are 100% sure that this is the amount of gas which is going to the patient. And we have a facility to show the set.
Okay. One thing I wanted to say, that if the FiO2 is going, you are already measuring the flow beforehand, giving it to the patient. But ultimately, what is the FiO2 the patient is having? I think that should also be measured.
So it is measured here. It is measured here. And in fact, what FiO2 you have set is going to the patient definitely. Unlike the other machines where you have to measure it, here it is, as is true of all the invasive ventilators, in this machine, you don't have to measure at the patient end. We are giving you the exact FiO2 that you have set.
Yeah, can I go ahead?
Yeah.
Okay, thank you.
Thank you. So that was about the HFNC mode. Then comes our popular Cpap mode, wherein we have again the Cpap screen shown. And if you see, typically the parameters what you adjust are the PEEP, FiO2 again, the apnea time. So if the patient is non-responsive, we will be able to detect that as well. Then we have the respiratory high alarm. If the patient is becoming tachypneic, we are able to check that as well. Again, the humidifier temperature and the pressure high alarm. If the airway pressures are somehow getting increased to a certain level, even that monitoring is a must. So all these things and parameters being shown. I would ask my colleague to first switch off the HFNC mode. Yeah. And now let us go back to Cpap. So we have the start Cpap knob getting activated. Let's start the Cpap. So here again the top waveform, the red one is pressure and the lower one is flow. So as the patient starts interacting, you can see the flows changing and the Cpap pressure diagram showing that it's trying to reach the set peak value. You will be able to see on the topmost waveform a yellow line and a red line. Yellow line is the set PEEP value and the red line shows exactly how the patient's lungs are interacting. Again, this is for the first time that any equipment is showing what is set and what is delivered. Because it is not necessary that whatever you are setting is getting delivered. The waveforms at times do not give you the exact information. Here you are able to see the interaction, the patient-lung interactions with the machine. So this is about Cpap. In Cpap, again, you have an hypoapnea or apnea detection possible so that the interaction can be taken, because in the rate column on the right side top column, if you see, the rate column was showing 21 and now it is 0. So it will be able to tell you that the patient is not responding. So that's about Cpap. If we have any questions, we can take or we can move ahead on the next mode.
Go ahead. We can have discussion at the end also.
Sure. So let's move on. Let's switch this off. Again, switching off a mode is as simple. You just stop it. Yeah. And you go to the BiPAP S mode. In BiPAP S, one more parameter has got added, that is the IPAP pressure and the EPAP pressure. Rest of the other settings are still there. So let us start the BiPAP S. In BiPAP S, this is a spontaneous mode. So yeah, please start. And since this is spontaneous, initially the machine is going to set you some PEEP level on which the patient is allowed to breathe in. When the patient breathes in and crosses the trigger threshold, he is given the IPAP pressure. And the moment he makes some expiratory efforts, you are able to sense the expiratory trigger as well and cycle him off. So a typical BiPAP S mode, you are able to see very, very emphatically the triggers, the inspiratory as well as the expiratory triggers. We need to understand how this patient is responding. A very small tool while we did the test was that whenever there is a inspiratory and expiratory trigger, we can definitely assume that the patient is doing all right, he's comfortable, and he's breathing well. And you are also able to see the rate on the right side top column. On the right side, again, you have the estimated volumes shown. So you have the tidal volume and the minute volume shown on the right side, second last and third last columns. So this is BiPAP ACE working. Again, if you see the pressure waveform, the delivered or the set is shown in yellow, and the exact one, the interaction with the patient, which gives you an idea about the patient compliance and rest of the things, is shown in red. I believe this will serve as a very important tool in people understanding as to how a patient lung behaves on a ventilator. We are used to very standard waveforms which are shown on equipments, and we assume them to be the interactions with the lungs. So this is what we've tried to show, that is BiPAP S. And suppose if the patient is not doing any interaction, definitely there is an apnea backup ventilation available here as well, since it's a spontaneous mode. Let's go to the BiPAP. Let's close this first and then go to the BiPAP T.
Abhay?
Yes, sir.
You must have seen wonderful triggers in 2 different colors. Believe me, some of the best ventilators would not show the triggers so clearly shown in our machine. Both triggers stand out very clearly. See the violet color and the other color there. And in fact, they can be very important pointer to know how the patient is responding. Also, again, you must have seen, we have shown the set pressure and the actual pressure. Most machines would show a beautiful graph showing a set pressure. Here you see yellow and red color graph. So we had a lot of debate amongst ourselves. Because what happens is an average user would see, what the graph is going like this. That actually happens. But most people don't show that. They just show a very beautifully shown graph. And our software talent, there's, Dr. Devjari, we can show a beautiful graph. I said, let's do one thing. Let's be different. Let's show what we have set and also show what actually is happening. So that is the beauty of graphics in this machine. And, Abhay and Tejas and all our team, I must really acknowledge their efforts for able to show such beautiful graphics live on a ever leaking system. Remember, this is a non-invasive ventilator. It's not a closed loop ventilator. And in such a ventilator, to show such graphics, you really need technical knowledge of a very high end. Yeah, please continue.
Thank you, sir. So that was BiPAP S. And then we have the BiPAP timed mode. Yeah, please switch it off and go to the BiPAP T. In BiPAP T, one more adjustment of rate has got added, and the IPAP time is 2. So for example, here, since we have a rate of 20 and an IPAP time of 2, so that makes it 40 seconds for inhalation and 20 seconds for exhalation. Or the EPAP pressures will be for 20 seconds and IPAP pressures will be for 40 seconds in total. So I would ask my colleague to please change the rate to 10 so that we have the scenario where we will have 20 seconds for inhalation, IPAP time, and 40 seconds for EPAP time. Please start. So this is where I think the beauty of verified waveform comes into. We call it as verified waveforms. The pressures are being delivered the way that you want, but due to the compliance of the lungs, and since we have also changed the peak flow times, you are able to get these kind of waveforms. So that is about the BiPAP T, and in BiPAP T, the machine will be delivering you the EPAP, IPAP at whatever rate you have set, and the patient is allowed to breathe at both the pressures freely. So that is about the BiPAP T. Let us go to the next one. Please switch it off and go to the BiPAP ST. So in BiPAP ST, again we have introduced a rate high alarm, which will check for the rates or the tachypnea which could happen because of inconvenience in ventilation or due to so many other parameters. Let's start this. We are on BiPAP ST. Let's start. In BiPAP ST, again, the set rate was there already. And now the patient is free to have his own triggers. I would ask my colleague to demonstrate that.
Okay.
No, they are on. Yeah. So this is a trigger. That's the one was a mandatory breath and one was a triggered breath. Again, the mandatory breath if the patient is not triggering, and this is again a triggered breath when the patient is triggering. So this is how it goes. You are able to see the change in rate as well. The estimated tidal volumes and estimated minute volumes are there for your help, which are estimated, which gives you an idea about how your lungs are behaving. In the adjust menu, Nirmal, if you can press adjust, please. Yeah. In the adjust menu, what you have is the apnea detection slope. That is the way you want the flows to increase right at the start of the inspiration. You have the trigger values, which you can make it sensitive or less sensitive, and the inspiration cycle to cut off your inspiration cycle. So these are the extra adjustments which you already have. Yeah, you can take that window off, and this is what we have. All the alarms, active alarms, will be shown in the alarms menu. And if you have any events which have occurred in the past, that can be also seen as a history in the events menu. Yeah. So, yeah, please go to the graph menu again. Yeah.
Okay, I think we got understanding of whole equipment and all modes. Let our pediatric expert comment so that.
Ghosh, please.
Yeah, in this, the last which has been shown, one I wanted to ask, what was the mandatory breath and what was the triggered?
Okay.
The color of the graph.
Fine. So the set rate that was there was 10. Okay. And now if you see if the patient is triggering, you are able to see 10 here on the window. And when the patient triggers, there is an averaging method used so that you don't have false triggers being noted. I have taken 3 triggers in a row and you see the rate changing. Okay, please do this. So if you see here on the window, you are able to see 10 was the set rate and 15 is the rate at which he is right now breathing.
Right.
Yeah, I hope I've answered.
Actually, I am not able to discriminate which one is the mandatory and which one is the triggered.
Okay, I'll show it to you again. Please don't trigger. So now this last breath, what you're seeing is a mandatory breath, and the one with the triggers shown is the triggered. This is a mandatory breath.
Yes, right.
Okay, I'll show the mandatory breath again. This is another mandatory breath.
The breath, yes.
And then I ask for the trigger. This is a triggered breath.
Okay.
This is a triggered breath again. Okay, and you have that expiratory trigger also shown, wherein the inspiratory cycle is off.
Yeah. After the blue with the pink color, which is coming, what is that?
That is the expiratory trigger.
Expiratory trigger. Okay. Right.
Yeah.
Dr. Dev Pujari,
Yeah.
can we use it as a transport ventilator?
I mean, yeah, it can be used. In fact, now the new model that we have is a blower-based model. So it has an inbuilt blower. So the air source is not necessary there. And what you need is only an oxygen source. And in that case, this machine can be definitely used for transport. It is available
then-
now. I think, yeah.
Now, anyway, it has a Wi-Fi connection.
Yeah.
Can a doctor operate on an app on mobile?
Yeah. Now that question, see, in fact, this machine has all the capabilities. Like it can be updated online. Online we can study everything. Only thing is, I studied the issue of app for ventilators. Now, app for ventilators would mean the problems of transmission. Like we just saw 5G interfering with Boeing. So by and large, app can be used for monitoring, and that we can easily connect this with a wire to show a monitor where we can show the waveforms. But it is not certified that you use an app which would change the ventilator, because a lot of interference could happen. It is nothing difficult. I mean, making an app for manually is not difficult, but it is really not advisable that way.
I'm just trying to show you our model which we developed. Because this could be remotely monitored. And you can
Right.
Can you see my screen?
Yeah.
You can have multiple ventilators connected,
Right.
and then you can have what you call as desktop sharing, which can be
Absolutely.
seen everywhere. You can have Wi-Fi sharing, camera sharing, so that it can be seen. And this whole thing could be controlled centrally. And the advantage is, once we have a good connection with Wi-Fi, ICU specialist sitting in district place can monitor all taluka place or maybe interior. Other thing is, anyway, for COVID, we'll be exposing less. This was one of the model which we wanted to study and maybe you can operate. But anyway, I think
yeah. Now this
I have something to add, Dr. Jam.
Yeah.
Yeah, the model is perfect. In that model, one thing which was not possible was that unless the equipment manufacturer allows insight into his software, you are not able to change or control the settings. So what we did was we added that feature into our software so that it becomes a standard. The moment you go for the IoT base, it's all ready right now. We thought we'll first do 100% on the ventilation and the parameters. These parameters are already tested, and we can do even the adjustments remotely once the clinicians and engineers agree to it, that fine, this is a protocol which is safe enough to use. Because when we were doing that, we came across a few papers which were published by a lot of physicians wherein they disallowed remote settings to be done, because if in an ICU where the ventilator is kept, you don't have a learned staff who can even change the settings, for that matter, should not be used. It was contraindicated. But definitely that feature we have worked upon, we have tested it, tried it, and ready for use in coming days. With our machine, you have the source also available, sir. So what happens? You are able to even change the settings remotely from anywhere in the world.
Yeah. Did you apply for patent?
Not yet, because Dr. Devpujari wants things to be more open. He doesn't believe in patents and all. He said, make it widely available.
Yeah, in fact, I honestly have not patented any of my devices for this. I said, this is for good human use. And that's why I said, let's do it. And, if somebody can replicate it, it's fine.
No. If you make it patent, it becomes more popular. You can have no fees for patent.
That's right. So we have 5 patent applications almost ready. And as you rightly say, a lot of people are asking us, and we will be putting up those. Like, for example, the actual pressure and that has been demonstrated is one of them. The 2 triggers been shown in such graphs is second. Third is we have adjustments for flows for pressure as an inbuilt part of this. So these 3 things are already there, and they're unique to our product. And I mean, yeah, we are debating, but I agree with you. A lot of friends are asking us to patent, and we will be doing that soon.
So what are the various IoTs you are using this machine?
Right. In fact, sir, that's a very interesting question. In fact, we already have an algorithm where you put patient's length and his age and integrate it with my ABG app. So the moment you put length, you can calculate the ideal body weight. The moment you calculate ideal body weight, 6 ml per kg will be the tidal volume. Since we have the ability to measure the tidal volume, we will be able to change and optimize pressure in such a way that it will deliver the tidal volume into heart rate, which is a minute volume. So the algorithm itself will adjust the requirements of the patient. After about half an hour, get an ABG done, and my ABG app is fully equipped to actually diagnose an abnormality. None of the ABG apps across the world have an ability to diagnose. They can only give you a diagnosis metabolic acidosis, but my app can give you renal tubular acidosis type 3. So we are working on that, and I'm very sure in a few months we will have a closed loop system where you just mention the length of the patient and his age, and the machine with the doctor's permission will suggest the adjustments to be done. And we are almost 90% through the algorithm. Other 6 months, I'm sure we'll be able to feed this algorithm to the machine. So the suggestions would be from the machine. If the clinicians want it, he can choose for those suggestions.
Actually, all these algorithms you can have input from waveform analysis.
True, sir.
Because all these waveforms have physical properties, and it's quite easy for an AI system to work on a constant physical properties.
Absolutely.
And I think you could put a better algorithm through that, and that will make your machine safe and more effective.
Yeah.
Anyway, I think it's a wonderful idea. Please accept. Congratulations. So I think it is one of the best things. So I understand far less ICU mechanism.
So one question I want to ask, how we are what about the humidification? It is inbuilt, or we are attaching something for humidification?
So you can see humidifier there. Now, you must have seen all ventilators have humidifier, not as a part of the machine. One of our strategies of reducing the cost was to put ventilator as a part of the machine so that we have saved on the microprocessing cost. This is a smart humidifier. So this humidifier is as good as any other high-end machines humidifier using the standard accessories. And you see, we are showing you the world-class accessories that are fitted in this machine. Please appreciate the way it is built. It's built like any other machine anywhere in the world. It's a very sturdy machine, very easily removable attachments. And as you rightly asked, we could save a lot of cost because we are saving the microprocessing cost separately for humidifier. That is an integral part of the microprocessor used for machine. And so as is true of all of the machines, it actually measures and looks after the humidity that gets into the tubing so that you don't have a problem in that relation.
So what are the various alarms that you have built in?
So all the alarms are there. There are high pressure alarm, low pressure alarm, rate alarm. So all the required usual alarms are there in this machine.
So I wish to connect it to a watch. Because the moment there is some alarm, there has to be vibration on the wristwatch.
Right. So
that patient which died yesterday, there was an alarm, but then nobody bothered because they didn't look at the alarm.
Oh.
So that suppose now I have an Apple Watch.
Right.
So it gives me vibration. So that I will go and see that patient.
Yeah.
It's a simple technology.
Yeah.
In fact, sir, my ABG app is the world's first app on iWatch. This was inaugurated in Johns Hopkins about 3 years back. On this Apple Watch, if you download my ABG app, it comes on your iWatch, and you tap on that iWatch. You can set the parameters which can go to the user. And and it can be done, but at this moment we're trying to work on the algorithm that I said. I feel this would be a good algorithm for our country.
Yeah.
But then
in
this point will
addition,
definitely
Apple
be-
Watch would be as costly as your ventilator.
Exactly.
Yeah, yeah.
And that is very true. That's very true.
On how many patients you have tried this now? Use this machine.
Yeah. So this machine is being used now. So we have about how many machines we have sold till now?
Up till now, 82 machines are deployed, out of which 63 machines are already working. The rest of the machines are at a couple of RHS, rural hospitals and all, which were not used. But 63 machines are very regularly being used, and we have feedbacks available with us.
So do you have any clinical data of all these patients managed on 80 machines?
Can I come in, please, Chair?
Please.
Dr. Jamkar. Dr. Jamkar, can I come in? Bijon Mishra here.
Please, I think Dr. Jamkar is probably muted. Yeah, please come in, Dr. Bijan.
Yeah. So, first of all, let me congratulate Dr. Satish and team and all my friends who are engaged with this innovation. I feel very delighted. I heard somewhere somebody asked about the price point, which I also wanted to know. How does it compare with the conventional equipment and your innovation? And how do you plan to escalate it in a manner that it is made most accessible and affordable to patients? And also, I'm very eager to know about your plan in terms of your capacity building and how you can encourage young entrepreneurs to come into this business with your technology, so that, as you know, India has become a great kind of a country to innovate and make it go commercial globally. So, Abhay, by the way, fantastic presentation, and very well, you made us walk through. It couldn't be simpler for a non-technical person like me, who is not a medical practitioner, who works on advocacy on patients' rights, and coming from a management background with marketing as my major. So that is why I'm keen to know, how do you plan to market it? Do you have a marketing team? If you have, please get them in touch with me.
Sure. Definitely. I head the sales and marketing wing of Satej, apart from being an academician for the research wing. Since Dr. Dev Pujari is totally away from the commercials and everything, there has to be a face to it. And as Satej, I would represent the company as the sales and marketing head.
I've shared my phone number and my email ID on the chat box with you directly.
Fine, sir. I'll just take it down and note it down before we end the session. Coming to the capacity building, we went through the mechanisms available at that point in time, because when we built this equipment, actually everything in the whole world was closed. And with the resources available, we not only built this equipment, but we also built a capacity to build these equipments in numbers. So we got hold of some very, very innovative and high-end manufacturers who could get into it. And we set up their plants, because that was the easiest method we could have done it. And with that, today we have a capacity of about 30 machines per day. That capacity is already in-house. We are talking to 2 technology transfers, wherein we will be transferring the technology to them non-exclusively, and they wish to take it up into manufacturing and marketing it further. So this is the way we are wanting to propagate. We have our own team through which we are doing the sales and the marketing and the service as a primary setup. In Nagpur and around, we have about 115 machines planned to be given to several rural hospitals, including AIMS, Nagpur. We will be having a couple of equipments there. And further on, now we have come up with another model.
Any machine in Pune?
Pune, we have given it to DY Patil, sir.
Okay.
Any machine in Hyderabad?
Bharti Hospital.
Any machine in
Bharti Hospital.
Hyderabad?
No, not in Hyderabad. We are in talks with Rainbow for a demonstration, but since this Omicron wave stuck up, people could not move and we could not take that equipment. The moment it settles down, I think we have that demo already lined up.
What about service team? Do you have some service team available?
Yeah. As a background, I have been into ventilation for the last 28 years. And in this part of the country, I have been a distributor and a supplier for a machine from Mackay Medical, which is a Getting a Group company. Before that, it was Siemens. So I have been representing that as well. So we have a service team already in place with 3 engineers based out of Nagpur, 1 engineer based out of Pune to support these equipments. And that's growing as the time comes by.
What is the price of machine?
Great. So coming to the price point of this equipment, sir, we have priced it at, almost 1/3 of the comparative equipment that we are comparing it with. We had V60, Philips V60 as the model which we had in mind when we designed this, and we wanted to better that. So that equipment, for an example, if it's available at X cost, this is to be available at 1/3. Our price in the market today is going to be 3.5 plus taxes, which is inclusive of humidifier and accessories altogether.
Very good. Congratulations.
Thank you so much.
So let's be in touch. You have to fight a big brand called Philips.
Yes, I will get in touch with you.
That needs a lot of soldiers, good warriors.
You do need
Get in touch. Get in touch. I can only advise out of my marketing competency, but there we need soldiers to spread this. And great, Dr. Satish, once again, keep up your great work, man. You're doing marvelous work, marvelous. You should, and I like that sentence of yours that you don't want to patent. Excellent. I really admire you, man. You are an icon. You are an icon. Let's build on your innovations. Let's make India the dynamo to take technology to its next level. We are full of talents.
Yeah.
You're full of talents. So while you enjoy now, don't forget India.
No.
He's back.
Dr. Jamkar, please, your final comments and should be.
Yeah, I think
I invite Dr. Ghosh also, Vidya Ghosh, for final comments, and then we conclude.
Yeah, this great job being done by Dr. Satish Pujari and the team, and I really congratulate them, and I hope for the best. And I think that not only in India, in our other countries also, we will spark with this ventilator, and I wish you best of luck to them.
Thank you.
Congratulations, Dr. Pujari, again. I think it is one of the excellent machine. I think it's one of the best creation an intellectual can have. And I appreciate all your creative intelligence where you think of both clinical side and innovation and equipment side. Let us hope that this machine reaches to the people at the bottom of pyramid. And I think I would request Dr. Mishra to connect with big players in this area. And because you are without patent, then they will be more than happy to market it. And our aim is it has to go to minimum, say, at least sub-district level or maybe taluka level everywhere in India. And that will reduce mortality of pediatric patients. You can expand your horizon by giving it to Latin America or maybe Sub-Saharan Africa. And I think the sky is limit. So let me thank you again for coming in and demonstrating, and thank Dr. Kalra for inviting me to chair this session. I enjoyed.
Thank you. Thank you, Dr. Pujari and Abhay and the team members, Dr. Ghosh. It is a wonderful, today we have a discussion and we saw the innovation, and it is really, we need to promote this. And can I have your, Mr. Ajay, your phone number? You can share on the chat box.
I'll do that, sir.
Yeah.
devpujari.com, and I also have a website arunjamkar.com.
Thank you, but it's nice to hear some good words, and
Just put your mobile and email on chat box.
yeah, okay.
And
Okay.
where it is installed in DY Patil, which I see.
Dr. Iyer.
Just one correction, Abhay. It's not DY Patil, it's Bharati Hospital.
Sorry, it's
Dr.
Bharti.
Iyer.
Yeah.
So Pujari, why don't you put your email as well?
Yeah, I'll do that.
Ashutosh, is my